Good morning. Thank you very much for joining us for this poster session on day 3 of the World Bronchiectasis Conference. We've got an exciting lineup of presentations this morning. As the title suggests, we're going to try and cover the length and the breadth of bronchiectasis in this poster session this morning, going from comorbidities, the microbiome, PCD, physiotherapy, and registries. My name's James Chalmers from the United Kingdom. I'm going to be one of the chairs, along with Lucy Morgan from Australia and Michael Steinberg from Israel. We've got a number of posters to get through. The instructions to the speakers is we're going to give you 3 minutes to present the overview of your poster, and then we'll ask questions. All of the other poster presenters are in the session and can ask questions as well, and we'll try and get through all of the posters in the allotted time. So with that, I'll pass over to Michael to introduce the first poster.
Yes, good morning. So the first speaker is Holly Keir from Dundee, United Kingdom. Her title is Elevated Sputum Neutrophil Elastase is Predictive of Microbiome Dysbiosis and Disease Severity in Bronchiectasis. So please share your slides, Holly.
Great, thanks, Michael. I'll just get those lined up for you. Hopefully you can see them.
Yes.
Perfect. So, as Michael said, my name is Holly Keir, and I'm a final year PhD student at the University of Dundee in Scotland, and I'm here today to talk about our work. So, sputum neutrophil elastase has been shown in previous studies to correlate with disease severity in patients with a bronchiectasis. In order to apply this marker clinically, we need to ascertain cutoff points that relate to clinically relevant subgroups of patients. The aim of this study was to establish sputum neutrophil elastase cutoffs, which best discriminate between patients with severe versus non-severe disease, and which best identify patients with microbiome dysbiosis. We enrolled patients in this study from a specialist bronchiectasis clinic in Dundee in Scotland, and we measured sputum neutrophil elastase using an activity-based immunoassay from ProAxis. Microbiome profiles were characterized using 16S RNA sequencing, and for the statistical analysis, we used receiver operator or ROC curves to evaluate discrimination of neutrophil elastase with outcomes of the bronchiectasis severity index and proteobacteria dysbiosis. We defined dysbiosis as greater than 40% operational taxonomic units, which is a cutoff that's previously been shown to be associated with the worst outcomes. Of the 225 patients who were enrolled, they had a mean age of 68 years and were just over half were female. There was a mean BSI of 7.8 and a mean QoL-B score of 62.7. These patients also had an average FV1% predicted of 76.5%. When we compared the clinical characteristics of these patients with their neutrophil elastase, we saw, as has been previously shown, that there was no difference in neutrophil elastase between men and women, and no correlation with age was observed. We did see a strong association between neutrophil elastase and BSI, and a weak correlation with FEV1. When we looked at the microbiome profiles for these patients, we found that elevated neutrophil elastase was associated with microbiome diversity as measured using the Shannon Immunodiversity Index, which is a measure of evenness and richness. We also saw that neutrophil elastase was significantly higher in patients with proteobacteria dysbiosis. When we looked at which taxa were highest, we found that the highest levels of neutrophil elastase were associated with patients with the dominance of Pseudomonas, Moraxella, and Haemophilus. When we evaluated the predictive neutrophil elastase cutoffs, Yoden's index suggested a cutoff of 7.4 microgram per ml, best predicted proteobacteria dysbiosis, and a cutoff of 10.7 microgram per ml was most predictive of severe bronchiectasis. We also saw that there was a statistically significant increase in mean neutrophil elastase concentrations at exacerbation and a subsequent reduction with antibiotic treatment. To conclude, the study confirms that neutrophil elastase correlates with disease severity in airway infection in bronchiectasis, and that an elastase cutoff of 7 to 10 microgram per ml is likely to be the most discriminating for identifying high-risk patients. I'd like to thank my collaborators in Dundee, and thank you for listening.
Thank you very much, Holly. So any questions from the other presenters? So maybe I'll just ask one question. So there's different neutrophil elastase levels for different bacterial species. So would you suggest to maybe use different cutoffs for different populations of patients?
So I'm not sure if you could, I think that using a cutoff would be useful for saying if patients are more severe. There is variation between the species, so though we did see like an increase in proteobacteria dysbiosis, it's not always a perfect correlation. So I wouldn't want to like set certain cutoffs and say, oh, if this was the cutoff, they have Haemophilus or Pseudomonas. But I think it is certainly useful for knowing which patients are likely to be more severe and what their microbiome might look like.
Right. Anyone else? So can we move forward to Holly-Ann Richardson also from Dundee, United Kingdom, short-term stability of the lung microbiome in bronchiectasis and cystic fibrosis.
I'll just share my slides. Here we go. And then I'll launch it. Can you see my slides?
Yes.
And can you hear me?
Yes, go ahead.
Okay, great. I'll start then. So I'm Holly-Ann Richardson. I'm a postdoc researcher at the University of Dundee, and I'm presenting data from a study we performed looking at the short-term stability of the lung microbiome in bronchiectasis and cystic fibrosis. So bronchiectasis is a heterogeneous disease, and it presents with a wide spectrum of clinical phenotypes. The microbiome characterization is increasingly used to investigate bronchiectasis pathophysiology and to advocate for personalized medicine. So using a single sputum sample to analyse a patient's microbiome profile in order to guide therapy is dependent on demonstrating that there is short-term stability of the microbiome in the absence of antibiotic treatment. So the objective of this study was to investigate the stability of microbiome parameters over 2 weeks in bronchiectasis and cystic fibrosis patients. So the patients were enrolled and they were clinically stable, and they provided spontaneous and 24-hour sputum samples at baseline, day 3, 5, 7, and 14. The samples then underwent DNA extraction and 16S ribosomal RNA sequencing was performed, and this was done on the Illumina MiSeq platform. The data analysis was performed in CHIME, and we assessed alpha and beta diversity. So we had a total of 10 patients enrolled to this study, 5 of which were bronchiectasis and 5 were cystic fibrosis. And you can see the clinical characteristics for these patients in Table 1. So if I move on to my results, if you look at Figure 1, we used principal coordinate analysis using the Bray-Curtis index, and we showed that the microbiome profiles were highly individual, with clustering within individuals and limited overlap between individuals. Alpha diversity parameters were also relatively stable within individuals, and this can be seen in Figure 2. The coefficient of variation for the Shannon-Wiener diversity index within individuals ranged from 1.6 to 89.9%. There was no difference in the alpha diversity between the 24-hour sputum samples and the spontaneous sputum samples, and this can be seen in Figure 3. The coefficient of variation for the 24-hour sputum samples ranged from 3.7% to 72.9%. We used random forest analysis, and we observed that there was a loss of specific taxa in the 24-hour sputum samples compared to the spontaneous samples, and these taxa included Prevotella and Pseudomonas. We also went and looked and assessed the stability of the microbiome profiles in the cystic fibrosis patients compared to the bronchiectasis, and there was greater stability in the cystic fibrosis patients compared to the bronchiectasis patients. So to conclude, it's important that we consider this as a small study with only 10 patients enrolled, but we've demonstrated that there is relative stability of microbiome profiles within individuals with cystic fibrosis and bronchiectasis over a short-term follow-up. And this suggests that single high-quality sputum samples are representative of individual patient microbiome profiles in clinical research studies. Thank you for listening.
So thank you very much, Holly-Ann. And any questions from the presenters? And can I ask again, you said that over 24 hours, so if you took 24-hour sputum samples, some of the taxa were lost altogether, or just less quantity?
There was a loss, and I think it's because the 24-hour sputum, like they were coughing into the pot all day, so it was sitting around for longer than. So if you're doing a trial or you've got a patient coming into clinic, they cough up, you take that sputum, you either process it straight away or it's stored at -80. If the patients were coughing up over a period of 24 hours, it's sitting there for longer, so that's why there was a loss in the 24-hour samples.
Mm-hmm. And was there a difference between the CF and the bronchiectasis in terms of you said that CF were more stable. The bacteria.
Sorry to cut you off. So the CF patients, they were more stable, but their microbiome wasn't as diverse. So it was dominated by something. So you're not going to see, it's going to appear more stable because it's not as dynamic and it's not as diverse as, say, the bronchiectasis microbiomes are.
So would you suggest that if a microbiome is stable and less diverse, it's more stable within bronchiectasis as well?
Yeah, because if I look at so obviously there's 5 patients, but 2 of them are dominated by Haemophilus, and then 2 of them have got like normal respiratory flora, some streptococci, and then the other one is Pseudomonas. Yeah, yes, there is stability. They are dominated by one there is something dominated, saying like there's like 30 to 40% of the reads are one organism. So yes. Hope that answers your question.
Yes, thank you. And was that all fresh sputum, or did you have any lavar samples as well?
No, this is just all sputum.
Okay.
I don't think we could have done taking doing bronchoscopy on them over 2 weeks. I don't think they would have liked that.
Okay, so I see that already the next speaker has his slide. So Lucy, would you like to present the next speaker?
Thank you. Thanks, Mikhail. Look, it's lovely to be able to introduce one of my own colleagues. I'd like to introduce Dr. James de Michael, who works in my unit at Concord Hospital in Sydney in Australia. Thanks, James.
Hello, friends. I hope you can all hear me.
Yes.
Yes, and you can see my slide. So my name is Dr. James de Michael. I work in Concord Hospital, Sydney, Australia. I'm presenting our work, which is, let me just minimize the video, sorry, which is entitled Mucociliary Clearance in the Healthy Trachea Occurs in Spirals, and it's impaired in COPD, absent in PCD, and acute viral infection. So basically, we wanted to measure mucociliary clearance in the airways in 3 dimensions, knowing that it's critical to lung health, and impairment of mucociliary clearance is seen in a lot of conditions, including bronchiectasis, asthma, COPD. We studied 3 non-smokers, 12 ex-smokers, and 5 patients with PCD. In each patient, images were obtained by both coronal and sagittal gamma cameras, enabling 3 dimensions, after injection of radiolabeled albumin through the cricothyroid membrane. One of the non-smoking subjects was opportunistically studied with an acute influenza B infection, and we used custom software to track the peak intensity of the bolus. So this is a few images of our methodology. That's myself injecting someone people might recognize as Lucy Morgan, just to demonstrate on the bottom left is the images that we obtain, where you get both coronal and sagittal views. At the top there's the injection site, and you get deposition of the mucus just above the carina, which then ascended the trachea over the next 15 minutes. Now our result, we got coordinates of the sputum as it ascended the trachea, and plots were compared to both a linear and spiral mathematical model of movement. And in that, spiraling was proven to be much better fit in 3 out of 3 non-smokers and 9 out of 12 ex-smokers. The remaining 3 ex-smokers had insufficient movement for assessment, and of course, there was not much mucociliary clearance occurring in the PCD patients. Further results, we found that Keftalad, or horizontal mucociliary clearance velocity, was significantly reduced in the ex-smoking cohort at 2.7 millimeters per minute compared to 8.8 millimeters in the non-smokers. We found the impairment of the Keftalad velocity was caused by changes in the spiral angle, meaning that though the ex-smoking or COPD cohort had a much shallower or smaller spiral angle compared to the non-smokers at 18 degrees compared to 47 degrees. You can see that in the pictures on the bottom right is a COPD patient. It spirals at a much shallower angle and takes longer to clear. Interestingly, spiral angle correlated very strongly to FEV1. The lower FEV1, the lower spiral angle, and you reduced Keftalad mucociliary clearance velocity. And it didn't correlate with the speed along the path. just to show what was happening in our PCD patients, as well as acute influenza B infection. They appeared very similar. After injection of radiolabeled albumin, it tended to coat the trachea, and there was no real bolus formed over 15 minutes, and there was nil movement, which indicates, I think, deciliopathy and deciliation associated with each condition. So in conclusion, this work describes a novel way of assessing the mucociliary clearance in 3 dimensions and shows that, or potentially shows that normal mucociliary clearance occurs in spirals. Clearance is impaired in ex-smokers and correlates with FEV1, and it is the change in spiral angle rather than the speed along the spiral path that causes impaired horizontal or cephalate clearance in ex-smokers. Clearance is absent in PCD without bolus formation and appears very similar in imaging to acute influenza infection. Thank you very much.
Have we got any questions for James from the other presenters or from my co-chairs?
Could I ask a question? That's really fascinating work. You said that the main change that you see in COPD patients and ex-smokers is the change in angle. Did I understand correctly that the angle's flatter?
The angle is much flatter, correct.
And so what would be the mechanism of that? Have you got any theories as to why mucociliary clearance would still be present but would be flat?
Yeah, it's hard to know. It's obviously associated with patchy deciliation. I think we need more studies to really delineate what's the pathophysiology of what's happening, but it's associated with deciliation, mucus rheology. We're just kind of guessing as actually what's happening. I don't think gravity is a factor there because they were laying flat under the camera. So yeah, it's some form of deciliation that's causing just a flatter angle, but obviously we need more investigations.
Yeah, and you've chosen to focus on the trachea. I guess we often think about mucociliary clearance sort of further down in the lung than the trachea. So what was the thinking there?
Well, it's probably just a limitation of our methodology, because we were as a percutaneous injection through the cricothyroid membrane, and it would deposit. Sometimes it would go into the left and right main bronchus, but then we have to track the peak intensity of the bolus. So we decided to track it from just up the trachea because it's the best that we could get from our technique, just to deposit through the trachea rather than the smaller airways. It wasn't inhalation, it was an injection through the cricothyroid membrane.
And what's the plan for using this? Is this going to be a diagnostic for PCD, or is this going to be, how are you going to apply this?
I think going forward, it's a good pilot study and shows some novel findings, but I think the next studies going forward might be looking at the effects of mucolytic medications, see what's happening, whether they change the spiral angle. I mean, we've done some work using indicatorol, which shows that it does change the speed it increases the speed along the spiral path, but doesn't significantly change the caudal clearance. So I think we might be looking at different mucolytics and see, what's going to happen with the clearance there.
Fantastic. And I guess an obvious question is, how easy and how acceptable is it to patients?
Well, it's fairly simple. It was well tolerated by all our patients. And I suppose I've had some older physicians tell me that that's the way they used to anesthetize the airways and vocal cords in bronchoscopies earlier. So it's surprisingly well tolerated. And we used a bit of MLAR or a topical anesthetic to numb the skin prior. And it's a quick injection, so it's quite well tolerated.
Very good. Any other questions from the other presenters or from Michael? Yes,
James, did you do any non-PCD bronchiectasis to see how they're doing in terms of the movement, the spiral movement?
No, in the study numbers so far, it was just PCD bronchiectasis. We haven't extended to non-PCD bronchiectasis just yet.
Great. So thank you very much. Really fascinating work. Look forward to seeing.
You've got to give James some extra points for injecting his supervisor, don't you think?
I think all of the PhD students on the call probably want to do the same. So you got
a very nerve-wracking
benefit
experience.
Fantastic, really great
Thank
work,
you very
and
much.
I hope you keep going, and maybe we'll see more data on this technique at ERS next year.
I'm sure you will. Thank you very much.
So we'll move on to the next presenter, I've been looking forward to this because I love the microbiome. It's Stephen Taylor, and the title of the presentation is "Exploring the Relationship Between Pseudomonas Inflammation and Bronchiectasis in a Lung Explant from a Patient with PCD."
Thank you, James, and yeah, exciting to present just some early studies that we've done so far. So just as a bit of background, firstly, can you all hear me and see me? It's always a bit weird when it's
Yes.
virtual. Okay, great. As we all know, PCD results in impaired mucus clearance from the lungs and can lead to productive cough and bacterial infections and bronchiectasis. And in the case of advanced lung disease, a double lung transplant is the only intervention available. And we also know that a major risk factor across bronchiectasis and a lot of chronic lung diseases is chronic infection by Pseudomonas with isolate morphology relating to disease trajectory, and also drift within the Pseudomonas is known to adapt to the airways and change its morphology once it's colonized. So with all that in mind, I set out to ask the questions: does the lung microbiota vary within an individual with PCD and severe bronchiectasis? And similarly, looking at the Pseudomonas itself, and does it vary with an individual? So to address this, we have a case study of a patient with severe bronchiectasis as a result of lifelong PCD. So this patient had respiratory failure at age 25, and then 18 months later had a bilateral lung transplant. And interestingly, for a long course of this patient's life, it was Haemophilus influenzae that was cultured from the airways, with Pseudomonas only cultured 18 months or 12 months prior to the bilateral lung transplant. So what was collected from this individual was sputum samples at 18 months prior to transplant and also 6 months prior. And from the actual explanted lung, we collected, Lucy Morgan, collaborator, collected 24 pieces of tissue that represent the 5 lobar bronchi from proximal to distal airways. And from this tissue and sputum, we looked at the microbiota, and also we cultured out Pseudomonas and performed whole genome sequencing. So what did we find? Well, from the sputum, even 18 months prior to the transplant, we identified a high prevalence of Pseudomonas, indicated in the green here. And that was also reflected at 6 months prior to transplant. And looking across all the different pieces of tissue in the lung, we actually saw Pseudomonas widespread throughout, indicating it was chronically colonizing all aspects of this patient's lung. And variations in total bacterial load was also observed, but that didn't necessarily reflect the localized disease severity or the prevalence of Pseudomonas or distal or proximal airways. So the actual nugget of kind of information that we were able to identify was pulling out the Pseudomonas isolates from the sputum and the 24 bits of tissue. So we identified we pulled out 37 Pseudomonas isolates, and whole genome sequencing revealed they were all the one MLST type. And looking at the genome, we were able to identify genes that encoded a mucoid phenotype, as well as piocyanin production and other virulence factors. And what was really interesting was we actually were able to identify evidence of genomic drift or pseudomonal core differences in the core genome within this Pseudomonas. And actually quite a substantial difference in the genome, where 130 base pairs in the core genome was identified between certain isolates of this Pseudomonas, whereas 0 to 5 base pair wobble is identified as clonal or the exact same isolate. So we did identify a substantial evidence of pseudomonal adaptation in the airways. So in conclusion, one patient with PCD and very severe lung disease, a single variant of Pseudomonas persisted, and that was even after the aggressive anti-pseudomonal therapy. It was widespread throughout the lungs, and the airway microbiota in this individual didn't indicate any variants throughout the lungs, or that there were non-pseudomonal non-pseudomonal taxa were actually rare. So we've got a series of future directions that we would like to do. It's a bit beyond the scope of these 3 minutes, but I'd just like to thank everyone here for that and take any questions.
Really nice talk. Thank you very much. Are there any questions from the other presenters?
Can I ask, he had Haemophilus and only 6 months before transplantation acquired Pseudomonas. So I wonder what happened to the Haemophilus. Where did it go? So almost no Haemophilus in the lung that you examined, right?
Yeah, the microbiota analysis revealed pretty much absent Haemophilus, and it was actually the 12 months prior to transplant was when Pseudomonas was found to take over, and that was reflected in the sputum microbiota as well. But yeah, it seemed quite clear that Haemophilus had disappeared and Pseudomonas had taken over, and not just taken over a portion of the lung tissue, but every bit of tissue that we looked at.
Mikhail, I'd looked after this girl for 20 years and I'd been doing lots of routine surveillance microscopy and culture, and had been Haemophilus, wall to wall since she was a tiny child. And then all of a sudden she had a prolonged admission to hospital, and almost certainly that was when she developed, when she caught this Pseudomonas, and it totally changed the direction of her life.
And another question is, at least in CF, when people get transplanted, some of the centers also do a sinus surgery to clean the sinuses and prevent reinfection with Pseudomonas. So did this patient undergo surgery, and if so, did you get samples from the upper airways as well?
No, she didn't.
I'll defer to Lucy for the surgery.
No, she didn't actually have sinus surgery first. She did have Pseudomonas identified from nasal secretions, but she didn't have pre-transplant sinus surgery.
And how long was the Pseudomonas before in the nose before it got to the lungs?
Same time.
Same time. It's really interesting. It's a rare case to be able to study this way, but it gives us a lot of information.
Can I ask a question, Stephen, just in general about the microbiome? We're sort of taught in review articles that there isn't a great correlation between sputum and tissue, but in this case there seems to have been a very good correlation. And similarly, the microbiome is different in different parts of the lung, which was also not true in this case. Do you think this is just the peculiarities of this case, or do you think that there's something different about bronchiectasis PCD?
I think this is a particular case. If you have a look at the CT scan, there was just, it wasn't so much that there was layers or different pockets of severe bronchiectasis. It was quite widespread bronchiectasis throughout all of the airways. And I'm interested in drilling into this particular Pseudomonas to see if it's quite unique in its ability to colonize widespread infection. But I think, yeah, there definitely are studies out there that have shown that within the tissue, it's actually quite diverse at different areas, and that correlates with the different severity of bronchiectasis. I think for this patient, because it was so severe and throughout the lungs, it was quite a heterogeneous microbiota. And that did reflect the sputum even 18 months prior, which, yeah, is quite distinct from the literature. And yeah, it would be interesting to know if it is just this particular severe case.
Fascinating case.
Okay, well, it's my pleasure to introduce, thank you, Stephen. It's my pleasure to introduce Ivan, who's going to talk to us about the feasibility and benefits of an innovative airway clearance device in COPD patients hospitalized for acute exacerbation. And Ivan's going to present some work done in Slovakia. Thanks, Ivan.
So thank you for giving me the opportunity to present this work from Slovakia in partnership with PhysioAssist. So the aim of his study was to assess the feasibility and effects of a new ACD device named Simeox in a comparative cohort study in hospitalized COPD patients suffering from chest congestion despite optimal medical treatment. So 32 moderate to severe COPD patients with acute exacerbations and symptoms of excessive congestion were treated during 6 days with medical treatment, pulmonary rehabilitation, and airway clearance with, in the control group, manual chest physiotherapy, and in the device group with Simeox. So usability of the device, the spirometry, CAT score, safety and tolerance were evaluated in both groups. So this device facilitates bronchial drainage by generating intermittent pulses of negative air pressure during relaxed exhalations. And the aim is to fluidify mucus and transport the secretions from distal to central airways to be expectorated by the patient. The device is used in many indications, ICF, COPD, bronchiectasis. So for the results, so the patients, as expected, were old, with a majority of male. Patients had severe disease and are symptomatic. 1/3 of these patients had bronchiectasis, confirmed by CT scan. A majority of them took ICS therapy due to asthma comorbidity. Control and device group have similar baseline data, except more ICS therapy in the control group. And the patients need a training during about 15 minutes during the first sessions, and no side effect, no pain were reported. Tolerance was good in all patients treated with the device. So FEV1 increased similarly in both groups. However, improvement of CAT score was higher in the device group. And in some subgroups analysis, it was interesting to see that in very severe COPD, improvement of FEV1 and quality of life was significantly higher in the device group versus control. And in small group of patients treated with the device and bronchiectasis comorbidity, it seems that the benefit of the device was the most in this subgroup, as indicated in figure 3A and B, where FEV1 and CAT score were improved significantly with a large effect size. So in conclusion, this result confirmed feasibility to use the Simeox technology in severe COPD to manage secretions. And this data suggests that it may contribute to improve respiratory symptoms and quality of life, and especially in the more severe COPD patients with bronchiectasis comorbidity. This data need to be validated in well-powered controlled RCT. Thank you.
Thanks, Laurent. I'm sorry. I'm sorry. I thought it was Ivan presenting. I apologize. Is there anybody with any questions for Laurent?
Laurent, can I just ask whether or what actually sort of was involved with the conventional chest physiotherapy, because that can be described in so many different ways, whether it be postural drainage or manual techniques. I'm just wondering what you used in your study.
Yeah, it was mainly breathing exercise, clapping, and sometimes autogenic drainage.
So not standardized from one to one, not the same airway clearance recipe for each patient? Individualized, not the same for everybody?
It was globally same manual chest physiotherapy with some in some patients with adaptation, but globally it was quite homogeneous.
Anne-Marie, do you have any concerns about that from a design point of view? Or
I think for the purpose of establishing the feasibility, it's really about seeing how this new technique actually works. So certainly no concerns from that perspective. I think it will be interesting to do sort of further comparisons in the future in terms of whether we sort of whether it's a more standardized sort of comparison around whatever forms that conventional chest physio sort of therapy technique. But it obviously has to meet the needs of the patients as well. So anytime that you're using postural drainage, you need to choose the positions, for example, that are most important to get drainage for that particular patient, as opposed to choosing generic sort of positions.
I have a question. Did you weigh sputum, or did you quantify the sputum that was produced? Yeah. And did you find
we have collected sputum, and after each sessions of drainage, bronchial drainage, and effectively it was higher in the device group compared to manual chest physiotherapy in terms of volume.
Laurent, can I ask you, do you anticipate there would be any sort of patient, any particular subgroup of patients for whom this technology or methodology would be inappropriate, that would not suit the patient?
These patients need to tolerate the device, so the setting of the device can be adaptably gently for patients who have a low tolerance. But we have tested this device in children, and the device was very well accepted, and even in very old patients that have a very severe obstruction. So it depends. For example, effectively in patients with severe hemoptysis, the therapy is not indicated.
Okay, if there's no more questions, thank you very much. Is that the last of our presentations?
Oh, I think we have.
No, we have 3 more to go, as far as I can see.
That's all right. I'm sorry, they just hadn't arrived. I thought maybe we'd have to wait till out.
That's okay. No. The next one is Anne-Marie, who you've already heard from, but talking about self-management and education in pulmonary rehabilitation settings. Anne-Marie?
Can you see my slides?
We can.
Yes.
Yes.
Okay. Thank you. So people with bronchiectasis are included in pulmonary rehabilitation. Hang on, I'll just.
Presentation mode.
I'm trying both options and they don't seem to be working. I'm just paused at the moment. Hang on, I'll start again.
Perfect.
Is that better?
Yeah, that's great, Anne-Marie. Thanks.
Thank you. So people with bronchiectasis are included in pulmonary rehabilitation, And we know that there's a mix of education topics, but the choice is really based around clinician preference, or it's been determined by what's relevant for people with COPD or ILD. And to date, the education needs and the topics of relevance for those with bronchiectasis has not been established. And determining the needs of this population will help to maximise this educational opportunity within a pulmonary rehab setting. So our study aimed to explore the perspectives of those with bronchiectasis on the topics of education, which could be included as part of a pulmonary rehabilitation program. This was a qualitative study informed by grounded theory, and we recruited our participants from the Australian Bronchiectasis Registry. All participants undertook a semi-structured interview. The interviews were digitally recorded and transcribed verbatim until we reached data saturation. So the transcripts were independently examined by 2 investigators and were fragmented into descriptive codes in the process of open coding. These codes were then organised to form themes, and the relationship between the codes and themes were refined until we came up with the final themes determined by the 2 investigators. We had a total of 21 participants undertaking interviews, and 6 of those had previously completed pulmonary rehab, and 6 themes were identified. The first theme was participants wanting to know more about their condition and in particular their prognosis, and this was well described by the second quote of, "All my life I found that bronchiectasis has just sort of slipped through the cracks. It just doesn't rate. Pretty much most of what I found out through my life is on my own." The second theme was participants seeking more knowledge about self-management strategies. And this is really highlighted again in the second quote, which states that, of course, I'm interested in anything that helps to keep me well. The third theme was around different options for airway clearance therapy, and in particular, patients wanting to know about different devices and what sort of hygiene practices they should follow. So most people didn't realise that the equipment that you can use and how to look after it. I had no idea how to clean them, or that you had to clean them, or how often. The fourth theme was around the role of physical activity, not just within pulmonary rehabilitation, but also at home. And the first quote stating that I probably would like to learn if there's any exercise or anything that I can do to improve it really highlights this point. The fifth theme was around treatment for extrapulmonary symptoms and in particular psychological challenges. And this is really highlighted with the first quote, which stating that a patient says they're not just a pair of lungs, you've got other parts of your body that do break down and you don't want that to happen because you've got enough to deal with your lungs. The sixth theme was around the different model of education delivery, and there were some contrasting findings, with some patients happy to mix with those of different conditions and others preferring to liaise and mix with those who had the same diagnosis. So there do appear to be some unmet educational needs of those with bronchiectasis, and these include the knowledge around the underlying cause and prognosis, different self-management strategies, what options there are for airway clearance and exercise therapy, and how to manage the extrapulmonary symptoms, including some of the psychological challenges of the condition. There were really mixed preferences for education delivery models, with some preferring a group type of model and others favouring individual sessions. And this information will hopefully provide the foundation for educational material development that could be provided within a pulmonary rehab program. Thank you.
Thank you very much for that presentation. Are there any questions from the other presenters? If not, I'll kick off with some questions. You had, I believe, 6 people who had previously undergone a pulmonary rehabilitation program. Did they give any different answers, or did the sort of having had some education and exercise discussions as part of rehab shape their answers in any way?
They certainly seem to have a better understanding of the role of exercise within the home and what sort of options there were outside of a rehab program, not just in terms of establishing that home exercise program, but exercise on an ongoing basis. That was probably the main thing that stood out for that particular patient population. And often they had undertaken, perhaps 2 or 3 courses of pulmonary rehabilitation as well. So that was really well embedded within their knowledge.
your point number 6 in the presentation about this sort of dichotomy, some saying I would really love to learn from other patients, and others saying I'd rather learn by myself. How do we tackle that? The fact that not everybody wants to learn the same or get information in the same way.
I think that's a challenging one, and I think it's almost a bit sort of, some of it is fundamental to some of the challenges that we have around how we actually go about delivering education within pulmonary rehab, regardless of diagnosis anyway. I think the important thing is to perhaps identify at the screening process or at that sort of initial assessment how patients like to learn. And where that can be accommodated. So certainly someone has a preference for more one-to-one sort of type education. If that can be accommodated within their program, then that's something that, if it can be aspired to, that's what we're looking for. But also have the other option of, for those who are happy to mix with a group of patients, regardless of sort of a diagnosis, that's also making that sort of available as well. And I think that the important thing is to identify what patients' learning needs are, and that's something that I think it still needs a fair amount of work sort of within this space in terms of this patient population to be able to sort of move forwards and then not just deliver the information, but deliver it in a way that's going to enable them to learn as effectively as possible.
And are you offering specific pulmonary rehabilitation programs for bronchiectasis patients, or are they still embedded within COPD programs?
Within Australia, yeah, they're still embedded, and that's mostly from a resource perspective, and I can't imagine that changing, although we're certainly seeing other models of rehabilitation around home-based and tele-rehab, and that may sort of shift this space slightly as well.
Great.
And that's something we might see more in the future.
Any other questions?
Just several comments about this. Is one of that I find that there's an Australian site with a lot of videos. It's a great resource, and this is one place I refer my patients, as well as the ELF site. So they're both really good sites for patients to get information and guidance outside of a formal rehabilitation program.
Yeah,
which
Michael Anne-Marie wrote the bronchiectasis toolbox. That's
okay.
her site.
So I'm so congratulations, it's a great resource. And another point is that I'd like to use this platform to advertise the ELF survey for patients, which has a few parts, and also one very important part is the physiotherapy that patients are using. So we'd really like to get as many responses as we can from international patients. So it would be great to have many patients answer this.
We certainly have a few patients accessing the toolbox. It was written for health professionals, but patients, as you say, certainly use it. So that's something that we can advertise on our toolbox to direct them to as well.
Fantastic. Thank you very much, Anne-Marie. And I can see that the next presenter's talk is already being projected. So we can move on to the next presentation.
Yeah, that's me.
Fantastic.
Hi, Aileen. Aileen's going from Imperial College in London, and she's going to talk to us about the utility of a discharge care bundle for patients leaving the hospital when they've had an exacerbation of bronchiectasis. Thanks, Aileen.
Thank you. Yeah, so my name is Aisling. I'm a respiratory physiotherapist in Imperial College in London. Bronchiectasis, as we know, is caused by inflammatory damage to the airways, characterised by recurrent exacerbations, with 1 in every 2,000 hospital admissions in the UK due to bronchiectasis. There is evidence supporting the use of discharge care bundles as they focus on best consistent and standardised practice. The use of care bundles that have been developed by the British Thoracic Society for conditions such as COPD and asthma have shown to be both feasible and have positive impact on the processes of care and clinical outcomes. However, there is not yet a specific bundle for bronchiectasis patients. Therefore, we aim to develop a bronchiectasis discharge care bundle incorporating the BTS quality standards to be completed prior to discharge from hospital, and then consequently audit our physiotherapy service after its implementation. A local audit of our physio service against the updated BTS guidelines was carried out in key areas of improvement were identified, which were airway clearance optimization, ensuring the provision of an individualized self-management plan, assessment and referral for pulmonary rehabilitation, and a range of secondary care follow-up. Based on these quality standards and input from the multidisciplinary stakeholders, the discharge bundle was created. Physiotherapists were educated on the delivery of the bundle interventions in a series of short education sessions and updated on the bronchiectasis guidelines. We also included training to give very brief advice for smoking cessation, as a trust, we are running a clinical improvement project to increase our referrals. We also acknowledge that a percentage of our bronchiectasis patients also have overlapping chronic lung diseases such as COPD or asthma. Therefore, we also include education sessions to upskill physios in teaching correct inhaler technique. There was an encouraging uptake of the discharge bundle, with the bundle completed for 79% of patients admitted. We found the percentage of patients seen daily for airway clearance increased from 75% to 79%, and airway clearance was deemed optimized for 100% of patients on discharge. We also an increase in referrals to pulmonary rehab, and all patients were supplied with individual self-management plans and secondary care follow-up plans. We also observed some association with reduced hospital readmission, with the readmission rate reduced to 13 from 33%. Overall, the use of the discharge bundle helped us achieve the BTS quality standards for these patients. Going forward, we plan to include sputum sample culture during admission as part of the bundle as per best practice. We also aim to formulate the bundle as a digital form in our documentation, which will enable us to extract patient data easily in the future. This project was limited to a single site and a small sample number. So going forward, we plan to implement the bundle across multiple sites and as standard practice with a larger population size, and evaluate it further with the view of potentially informing future guidelines. Thank you.
Thanks, Aileen. You get a prize for having the prettiest Christmas tree in your slide.
Oh, thank you.
All the rest of us are in offices and you're in your sitting room. It's beautiful.
Oh, thank you.
Can I ask you about the hardware of the discharge package? What does it look like?
So the bundle itself is, we have it formulated as auto text to go into as free text into our documentation. So it's a series of 6 kind of questions that we fill out. So on my poster here, it's in the yellow box. So that's what the bundle itself looks like. And then when we're prior to discharge, we implement that and just update as needed. So let's say, for example, in their self-management plan, we might include what airway clearance they're completing, or in their follow-up plan, we include the date of their secondary care or GP follow-up. So the date of the appointment is inputted as in the notes. So it's a free text, basically, we input into the documentation.
Can I ask how much time, so if I would like to implement something like that pre-discharge to the hospital, how much time with a physiotherapist or a nurse does that require per patient?
So we wrote, for this initial, we wrote this out with purely just physiotherapists. So going forward, the plan would be also incorporate nursing staff and or other AHPs. So the timing itself, in terms of training, we ran short sessions of 15 to 30 minutes with the physiotherapist that would be completing it. And then we ran them as kind of drop-in sessions, so it didn't interrupt the service. This was based on one site, so the training time didn't actually take that much time because it was a limited amount of people involved initially.
So about 15-30 minutes
per
in total.
session. Yeah.
And there were mainly patients that were in bronchiectasis centers, or just newly diagnosed, or?
It was mostly established conditions. So the patients that were admitted to hospital with bronchiectasis exacerbations. So the majority, I don't think actually we had any new diagnosis, so established bronchiectasis patients. So they came in, so majority either to an acute admissions ward or to acute respiratory ward.
So it's amazing that you managed to keep down the readmission rates, even if.
Yep. We were quite. I was quite actually surprised that the readmission rate dropped by so much, but we also appreciate that it's probably a lot of other factors that come into play with the readmission rate. So it was just kind of a nice observation to see in line with this.
Okay. So can I introduce the last speaker for today? Ms. Tu Kwan from Australia, the Australian Bronchiectasis Registry, Revision and Improvement of Critical Data Collection Platform to Inform Clinical Care of Bronchiectasis in Australia. Okay, so we're at the last speaker.
Lucy, do you know anything about the last speaker? With it being the Australian Registry poster, I would have.
Yes, it's the Australian Registry poster.
Like
I'm terribly sorry. I'm not sure why she's not online. It's been recorded and submitted, but I'm sorry, I don't know why it's not there.
Okay, I guess we're maybe too late to ask you to play the tape if it's been recorded, or is that possible? You don't have the recording. Okay, not a problem.
Sorry.
I think it's available.
It'll be available online.
Yeah.
That's great. So we've finished a little bit early because 3 of the speakers didn't come to present their posters. Do we want to ask any additional questions or have any further discussion? Or should we close the session a little bit early? I'm going to take silence as a decision to close the session early. I want to thank all of our speakers. That's some really high quality bronchiectasis research, and we really appreciate you presenting that to us and answering all of our questions. It's been really fun. This is the last of the poster sessions, which means after this, Mikhail and Lucy and I get to score them, and then this afternoon somebody's going to win, you know, the coveted World Bronchiectasis Conference poster prize. Maybe it'll be somebody from our group. But thank you all for participating, for taking part in the World Bronchiectasis Conference, and enjoy the rest of the day.
Thanks, everybody.
Thank you
Bye.
very much. Bye.
Thank you.
Bye.